Hi, I'm Ervin Valiente, a third-year nursing student, and in this video I will be talking about this particular disease that usually indicates a deficiency of vitamin B12 and folate. And by the end of this video, I am hoping that you will learn something from this disease. So, let's begin.
For this presentation, I will be talking about the hyperhomocystinemia. This will be the summary of the information that I gathered and you need to know about the hyperhomocystinemia. So, what is hyperhomocystinemia? First, let's talk about the homocysteine. And according to the National Library of Medicine, homocysteine is a sulfur-containing amino acid which is not supplied by the diet that can be converted into cysteine or recycled into methionine. It is also an essential amino acid with the aid of specific B vitamins. Homocysteine levels varies between men and women, with a normal range typically between 5 to 15 micromole per liter. So, to sum up, hyperhomocystinemia is a medical condition characterized by an abnormal high level of homocysteine in the blood. Usually, to determine the condition is hyperhomocystinemia is when the level of homocysteine exceeds to 15 micromole per liter. So, what are the risk factors associated with the disease? First, kidney disease per kidney failure, certain medication, and genetics. Next, what are the causative factors for hyperhomocystinemia? First is the insufficient vitamin B6, B9, and B12. Next is kidney problems are the failure to excrete homocysteine, or it can be also due to the patient's lifestyle. And lastly, the genetics or the defects in the PIF MTHF reductase. Next is how do we detect hyperhomocystinemia? A complete blood count or CBC test can be done to determine the levels of homocysteine present in the body. So the classification of hyperhomocystinemia can be categorized as follows. First is moderate, next is intermediate, and third is severe. Next, what are the signs and symptoms of elevated homocysteine? For the vitamin B12 deficiency, there is pale skin, malaise, fatigue, tingling sensation in the periphery, dizziness, mouth sores, and frequent mood swings. For the folate deficiency, there is fatigue, mouth sores, swelling of the tongue, and growth problems. And for the other vitamin deficiency that could overlap with this disease, first, muscle weakness or unsteady movements, shortness of breath, irregular heartbeat, mental confusion, forgetfulness, and weight loss. Next, what is the pathophysiology of this disease? As you can see on the screen, for the etiology, the insufficient vitamin B6, B9, and B12, it causes a deficiency of cofactors in the remethylation or transsulfuration. This is therefore integrates the methionines in a phase to use methylcobalamin or a vitamin B12 derivative as a cofactor. Both the CBS and the cysteine use pyridoxal phosphate, which is a vitamin B6 derivative as a cofactor. On the other hand, for the kidney problems, kidney fails to excrete homocysteine. Therefore, the MTHF reductase uses flavin adenine dinucleotide, which is a riboflavin derivative, as a cofactor. And for the genetics, or the defect in 5-MTHF reductase, causes a metabolic defect. This results in excess homocysteine entering the systemic circulation. On the other hand, genetic defects of MTHF reductase leads to impaired synthesis of MTHF, the first step in the synthesis of methionine. Okay, next. In continuation, so the body is therefore unable to synthesize or break down homocysteine. This causes a number of mechanisms such as, first, the excess number of homocysteine present in the body causes toxic effect to the body. This can be seen as the paleness of the skin, weakness, fatigue, tingling sensation, dizziness, sores in the mouth or in the tongue. And this mechanism is therefore how hyperhomocystinemia occurs. Next, what are the complications of hyperhomocystinemia? Complications could include osteoporosis, Parkinson's disease, dementia, myocardial infarction, stroke, cardiovascular disease, epilepsy, and end-stage renal disease. So, what are the medical management and nursing management and treatment modalities of hyperhomocystinemia? For the medical management, there is vitamin B supplement and antihypertensive drugs. And for the treatment modality, needed vitamin replacements could be used and provision of comfortable environment. And for the nursing management, first, assess and evaluate the homocysteine lowering intervention effectiveness. Next, supervise the patient's compliance to treatment regimen and provide a calm and quiet environment. And lastly, avoid strenuous activities. So, what are the possible nursing diagnoses for this disease? First, risk for bleeding related to elevated homocysteine level, fear related to unfamiliarity with the physiologic condition, its management, and treatment. Next is deficient knowledge related to unfamiliarity with the physiologic condition, its treatment, and management. And lastly, for the prognosis, the prognosis depends on whether the illness is treated as early as possible or not. Treating it as early as possible and providing the most effective and efficient nursing management poses a good outcome. However, if left alone, dangerous complications could arise.
And that's all from my presentation about the hyperhomocystinemia. These are my references. And lastly, credits to Ms. Mesa Lorna May L. of VSU for her YouTube video entitled Hyperhomocystinemia and Acquired Thrombophilia. This ends up my presentation. Thank you everyone and God bless us all.